And thanks, Sarah and Allison, for inviting me here today. My name is Erin Dorian. I currently work for Health Management Associates. Health Management Associates is the largest healthcare-focused consulting firm in the country. We were started by two Medicaid directors, so two former Medicaid directors, so we have really deep roots in public payer issues, but we also, work in state capitals across the country, and have a lot of policy chops around health policy, human services policy, aging policy. We really pride ourselves on bringing in experts from the field who have been in your shoes, done the work in state capitals, with service providers, and really helping our clients with anything that they need. I've been here for about 7 months. Before that, I was with the Hospital Association and the Maryland Department of Health. So I have been in Maryland healthcare policy for a really long time, and can talk a lot about how our hospital payment system really has shaped our entire healthcare system. I want to make this as interactive as possible. So if you have questions, feel free to stop me at any point, and we can talk about it. So the goal for today is to review and gain an understanding of the evolution of Maryland's hospital payment model, because we're moving into a new phase. We're moving into the AHEAD model, which is also going to be a partnership with CMS. And then I want to discuss some opportunities around agencies serving older adults. How is this going to affect you? How is this going to affect the older adults you serve? And what really opportunities are there for you all to partner with the state, with hospitals, to make sure that we are all really keeping older adults healthy and happy as long as we can. Okay, so why is this important to your organizations? The Maryland health system is very hospital-centric. It has been hospital-centric for the last 40 years because of this special relationship between the state and the federal government. And like I said earlier, that relationship has been evolving. It creates opportunities for flexibilities in federal law. So we can talk a little bit about that later. But because of this, special relationship, there really are opportunities to work within the system and test out new things. There is going to be increased focus on investments out in care outside of the hospital. This includes keeping people healthy and also providing care in more desirable settings than the hospital. It brings on end-of-life opportunities. We know that there are lots of costs at the end of the last 6 months in a person's life. And most people, don't want to die in a hospital. There's also money on the table for new models of care, for population health improvements, and, for additional partnerships. So this is something that I think everybody in the state of Maryland who are serving healthcare needs of any population should be aware of.
Did we lose Erin?
Hey, yep, it looks like we just lost her. So we'll give her a minute to rejoin. Hang tight just for a second. Hey, Erin, I think we lost you for a minute.
I am so sorry about that. I don't know what happened.
That's okay.
But, if there isn't a technology hiccup, then, what would this be?
That's okay.
So I saw a question in the chat pop up now that I am back, I can't see what it was since I was kind of kicked off, but, oh wait, yes, I can. All right, no questions yet. Great. All right. So I think I'm going to do a brief history of our unique payment system and the unique ways that it has evolved over the years. I apologize if you've heard any of this. Just tell me to move on. So our all payer system started in the late 1970s. It started in a handful of states. So Maryland at the time wasn't the only one to enter into special agreements with the federal government. Maryland is the only one that has kept those special agreements in place for 40 years. So what that means is the federal government payment programs such as Medicare and Medicaid agreed to pay the rates for inpatient hospital services that were set by the state instead of set by CMS. So the first principle at the beginning of this model was to reduce cost shifting between public and private payers. So what does that mean? Any patients, regardless of their payer type, can access any hospital service in any hospital in Maryland. We don't have public hospitals. The services are in Johns Hopkins are available to everybody that lives in Baltimore. The services, at MedStar Union Memorial, at any hospital in the state, they accept all payers. So, what does all payer mean? What is this lack of cost shifting mean? So the example that I always try to use when explaining to this is if there are 3 patients who were seeking the same service, let's say an appendectomy, at Johns Hopkins Hospital, and they had Medicare, Medicaid, and private payers. So they had 3 different payment types. Each payer would pay the same rate for that service at Johns Hopkins Hospital. In other states where hospitals accept Medicare and Medicaid rates set by the government, the federal government and the state, those rates are usually lower than private payers. So hospitals make up the difference by increasing what they bill private bill private insurers, and that's cost shifting. So at its outset, there was always an equity component to this model. So the evolution from the 1970s through 2014 was that all payer approach, but still in a fee-for-service reimbursement, model. So hospitals were incentivized if they wanted to increase revenue to increase services. So in 2010, some of the hospitals in Maryland started moving to what they call total patient revenue. This was the precursor to the global budgets that we're on now. What the reason for this change was, the cost of care was just getting out of control here in Maryland, and there was not as much of focus on providing high value care for patients. Hospitals always want to provide the best value, the best services that they can, but that there still was that financial incentive to provide more services in order to increase your revenue. So that was for total patient revenue existed between 2010 and 2012 in a number of rural hospitals in Maryland. It was really a test for what was to come in 2014. So in 2014, eventually every hospital and health system adopted global budget revenues. So what you get here, and I'll explain what a global budget revenue is on the next slide, is incentives to focus on keeping people well, and incentives on ensuring that there is the most appropriate high value care for the patient's condition. So how does this work? And the slide is looking a little hinky on my side. Can you all see it? Is it clear?
It looks great here.
Perfect. So on the left-hand side, you see the fee-for-service model. This is what was before 2014. On the right-hand side is the global budget revenue model that we're under now, total cost of care. So the idea is to ensure that hospitals have revenue that they can count on over the year at the beginning of the year, and predictable revenue for the year, but also provide incentives to keep costs down and provide the most high value care. So when they created the new contract with CMS, there were also okay, now I just got a note that it was being recorded and I knew that. So when the contract was created with CMS, there was this idea that by setting these global budgets at the beginning of the year, hospitals would have incentives to really keep people well. So here's the core of our current model, the components of the current model that we have. At its core is that hospital global budget. And again, as we just talked about, the basis for incentives for hospital to keep people healthy and provide high quality care. Then there are incentives for and opportunities for non-hospital providers to align with the goals of the model through value-based programs or investments in population health. And then the model also has these statewide health quality health equity targets around diabetes, opioid use disorder, and maternal and child health. So this is the precursor to really looking at population health as a whole, looking at these specific domains. So what's going to change? So when we are now in the 10th year of our 10-year contract, the total cost of care contract with CMS. And that means that we are up for renewal and there's opportunities to create some changes. So what's new in the AHEAD model? And the AHEAD stands for states advancing health equity approaches. Wait, I'm always going to get this wrong. Okay. States advancing all payer health equity approaches and development. That's what AHEAD stands for. So again, at its core are these all payer hospital global budgets. That's sort of the foundation. And what's new is there's an increased focus on primary care. There are incentives for the state to invest in primary care and ensure access to primary care. The federal government is also requesting further Medicaid alignment. So what that means is the Medicaid is going to be asked to make additional investments in primary care and think about how they are really using their dollars to improve population health. The state is also required to have a health equity plan, and the MDH is working on that right now. And there are going to be equity and population health outcomes that CMS will be looking at in Maryland, similar to diabetes, opioids, and maternal health, but they're likely going to be broader. Another difference is Maryland is no longer the only state that's going to have this model. 6 states were chosen to be in the AHEAD model. They are Vermont and Maryland is in the first cohort. Connecticut and Hawaii will be in cohort 2, and Rhode Island and 5 counties in downstate New York will be participating in this model. So here's Maryland's framework for success under AHEAD. There are 3 high-level goals to ensure high-value care, improve access to care, and promote health equity. And under those goals, there are specific targets and concepts that the state will be implementing over the next 11 years. There's also, like I mentioned earlier, this statewide health equity plan. So what's happening now is the state's health equity advisory group is meeting and developing that health equity plan. And then every hospital will have to have a health equity plan that rolls up into those state goals. We're really in the beginning right now. The contract was signed about 6 weeks ago. And we are expected to launch this in 2026. So I really want to discuss and have you all think about what are the opportunities in serving older adults. Hospitals will continue to have a focus on reducing avoidable admissions and readmissions. Like I said, there are opportunities in primary care. There will be additional investments. The Health Services Cost Review Commission, which is the rate setting commission, is really focused on that end of life care piece. And substance use disorder is likely going to continue to be a focus, along with population health improvements and chronic disease management. So I want to open it up. I'm happy to answer any questions. The next 2 slides are really for your reference. There include some acronyms that are thrown around a lot, and my contact information. So are there any questions about, the model, how it evolved, what it really means?
Thank you so much for sharing all of this great information, Erin. This is Allison. I was just wondering if you could speak a bit more about kind of the how. Like, a lot happens at kind of the hospital level that unless people have a really well-developed relationship with the hospital system, then how would a aging services provider, whether it's affordable housing or skilled nursing, how can they be a bigger part of this? And just any thoughts you have on kind of the how some of these broader opportunities might be actualized.
Sure. Yeah, I think, Allison, that's a great question. And the way that I think about this is, hospitals will have for some time, and, we can talk about whether these partnerships have been fruitful for aging services providers or successful. They have an incentive to really work with organizations that serve older adults. So, I think at the core, it's forming those good partnerships with your local hospital. That said, we all know that doesn't always work out the way that we all plan, or there are various reasons why that becomes difficult. I would say that where there are opportunities is to think about the populations that you serve and their needs for keeping them healthy and out of the hospital. What are some ways that you all as service providers can support that sort of chronic disease management? What can, how can you help connect your the residents and clients that you serve to primary care? Is there a way that you can think about ensuring that your clients know their end of life care options? I mean, I just went through this in my own personal life, with somebody very close to me at the end of her life needing hospice care. And she was not as connected to the care options in her community. So how can you make sure that everybody living in your community knows that you're around, and then be able to connect with your local hospital and, share your value proposition? You all know that you create great value for the older adults you serve. And, what is within the hospital's best interest to work. It is within the hospital's best interest to work with you.
Thanks, Erin. Are there questions from anyone else on the call?
So one other thing that I will say, I know that this is a lot. There's a lot of moving parts. There's a lot going on. It's very hard to get connected to, the decision makers here. And Allison, you were very good at ensuring that you are connected to the decision makers. I would say, follow along. It's hard to understand, what's going on in the healthcare system from the outside. Spend some time looking at the Department of Health, looking at watch a health equity meeting if you have an opportunity. I know we all are very busy, and that's really hard, but there's a lot of opportunities for public comment. For example, the HSCRC right now, and I can send this to you all, has a list of questions out for the public to comment on what is needed to be successful under AHEAD. They're very specific questions. They're on the HSCRC's website. And, maybe take a look at those. I'm happy to share those with you. They are really looking for input from the community and from organizations that serve the residents and the patients that end up in the hospital or are just here in Maryland. So try to stay connected, ask a lot of questions.
Great. Well, I don't see any other questions in the chat.
Can I just ask you all, just for my own kind of personal, I've been so steeped in this for so long. How many of you have heard of the total cost of care model, AHEAD, any of this?
This is the first time we're hearing of it from Maryland Baptist.
Yeah, and I think, that's really part of one of the changes that the HSCRC is trying to make. They're trying to connect more with organizations in communities that are serving Maryland residents. The whole, they will not be successful unless they have partners to keep Marylanders well. So I think there is a great opportunity to provide some feedback and think about, everybody is going to be thinking about their role in a sort of a different way.
Thank you, Erin. This was such a helpful overview, and I'm really excited that we have it recorded so that we can share it with people, because you live and breathe this stuff, but for most of us, like, maybe we've heard of it, maybe we haven't, but it can feel really overwhelming and technical.
Yeah.
So we appreciate such a simple, like an easy to understand overview. It was really helpful.
Well, great. And Allison, I'll be sure to share that HSCRC document with you. They are, looking to have the public comment, both, in written form and, going to the HSCRC meeting and testifying. I know that's a big lift for, service providers that are really caring for people right now. But I think, I hope that what happens is with these changes, there's more connectivity between hospitals and health systems and, hospice and palliative care, community providers, affordable senior housing. There has to be those connections and connectivity. We cannot keep living in our silos.
Great. Well, thank you again, Erin. And thanks for those of you that were able to join us today. I hope you have a great rest of the day.
Thank you.
Thank you
Bye-bye.
so much.
Thank you.